Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning, Lumbar Spine.
We're going to get right into the procedure today. I have a 14 by 17 cassette in the Bucky tray, and we've placed the ID blocker to the caudal end. In setting up your room, you do put the cassette in the Bucky tray, and I'm going to move my marker in a little ways because I'm going to show about 2 inches of collimation on both sides of the cassette. Some departments will collimate tighter in order to focus right in on the lumbar spine itself. Other departments will keep the collimation to just the edge of the film because they're doing survey work. They want to get the entire body on their collimate just within the rib cage. So you need to inquire into the philosophy of your department, know why they're taking the x-rays, and that can help you make some of your decisions. The tighter the collimation, the better it is for the patient, the increased contrast, less dose for the patient. However, back pain might be kidney pain, so some places do survey work, and they do not collimate down as tightly. Okay, we're going to talk to our patient now. I want her flat on the table, and I want her straight on the table. It's a really good idea for you to make it either step towards the caudal end of the table or come to the head of the table and make sure the patient is straight. I want you to watch here at the patient's waist. I'm going to have the patient bend her knees so her feet are flat on the table. And look what happens to the spine. Did you see how it went closer to the table? Dre, would you put your legs out straight again? See how it elevates up? And bend your knees for me. And that actually, I can't get my hand underneath the small of her back now. So it reduces the lordotic curve. So it is better if the patient's legs are bent. I would not bend them up too far, just kind of a moderate amount. There you go. Now the patient's hands can be either both down to their side or both up at the same plane. This will help to keep the patients balanced and not rotated. Again, either both down or both up. I caution you when they're down because patients that don't have a lot of adipose tissue on the back of their sacrum, they'll tend to slip their hands underneath, because the table's hard. For comfort, they'll tend to slip their hands underneath. So watch out for that if the hands are down to the side. We'll need to bring them out. If you have them up, just make sure they stay out of the light source, stay out of the collimated field. So I'm going to ask my patient, where would you like your hands? Are they more comfortable on your chest or down to your side? Okay, so she's going to put them down. If you shield your patient's reproductive organs, you need to shield very low. Most of our clinical sites like to include some of the sacrum. So we have to position the lead shield low, barely covering the ovaries. We're definitely covering the scrotum there. Okay, so again, my patient is straight, their knees are bent, both arms down or both arms up, and that the body is not rotated. Actually look at the anterior superior iliac spines, and they should be equal distance to the table. Okay. I will caution you on the patient's knees. Some room orientations, the door might be over there, and the patient's knees are elevated. If that's the case, I would definitely cover the legs with a sheet. Hospital gowns might be long, or the patient might be in pajama bottoms. Modesty is it's a concern in this exam. So keep that in mind. Sheets, pajama bottoms, blankets, something, protect their modesty. Okay. We're going to talk about part film reference points and actually position them on the patient now. Okay. Your collimation is going to be 17, and we're going to go approximately 10 inches on the gauge. That will give us 2 inches of collimation on both sides. Your part film reference point is the mid-sagittal plane to the center of the film. We'll look down at the patient now, and I'm going to float my table. And I have my finger on her xiphoid process. You can follow the rib cage up. There's her xiphoid process. That will tell me that the mid-sagittal plane is to the center of the film. I'm using a floating tabletop. If you can look down here, here's a centering gauge. I think you can see it on the table. It should line up with the center of the film. Floating tabletop, it's a good practice to line those two up. And then you can just push the bucky tray all the way in, and then we focus on the patient. The tube and the film will be lined up. Now we just have to center the patient. I'm going to step in front of the camera for just a second over here. It's actually easier to palpate the pelvis with your hands flat, both sides. I don't want you poking the patient. They'll tend to jump off on the table from you. It's uncomfortable, they're ticklish. So we're going to go flat-handed, and I'm feeling posterior. See how my hands are near the edge of the table there? And I'm feeling fairly firmly, and I'm going to find the top of the iliac crest. I'm having you feel more posterior because that's the actual highest peak of the iliac crest. And then the central ray will be 2 inches above that point. Remember, my tube and my film are already lined up, so all I have to do is float the tabletop and put the center of the film 2 inches above the iliac crest with the mid-sagittal plane to the center of the film. Xiphoid process is centered, and 2 inches above the iliac crest is centered. Okay. We've centered the film at the level of L3, the third lumbar vertebrae, which is 2 inches above the iliac crest. That's with the philosophy that L1 through 5 should be centered to the film. Some of your clinical sites or your places of employment will want the entire sacrum on, and so on a national level you might find the centering right level with the iliac crest. That's to include the entire sacrum and coccyx. So again, you'll have to ask the philosophy of your department, and you may have to adjust the centering just a little bit. Most of our places, again, iliac crest is 2 inches below the center of the film. Notice I said that 2 different ways. Center of the film is 2 inches above the iliac crest, or the iliac crest is 2 inches below the center of the film. Make sure you can talk either direction. It all ends up being the same. Let's look at our patient now. We're almost done with this projection. I set the collimation up to 10 by 17, but take a look at the light source on the patient now. The light source is right here. It's very close to the lateral portion of her body. If we wanted to include the entire abdominal cavity, all we'd have to do is open it up just a little more on this particular patient. You don't have to have the light skim the body. It just has to be very close to the edge, and we should have the entire rib cage on there in this case. The lead shield is very, very low, and the patient has actually raised her hands up underneath the pillow to help with the demonstration. But this is okay because they're both the same. If you are not photo timing, if you're not using automatic exposure controls, you will want to use the calipers. And you come in right where the central ray is, and you have your patient take a breath in, blow it out, and then you measure and look up on the chart, lumbar spine, AP. This says 17, so I'd actually look on the chart for 18. If you'll recall, they're only set up in, most of them are set up in 2 centimeter increments. Okay, so the patient is positioned. Knees are bent, mid-sagittal planes to the center of the film, and the center of the film is 2 inches above the iliac crest. You can instruct your patient, Dre, I'm going to have you take in a deep breath, blow it all out. Please don't breathe, don't move, and you may make your exposure. You're going to want to change films. We're actually going to use an 11 by 14 film for our obliques. I'm going to keep the ID blocker consistent. It's to the caudal end of the table. I'm going to adjust my collimator shutters to 11 by 14. And I'm going to come in side to side. I'm going to need to focus on the oblique now. See how I went a little tighter there? I actually have, the gauge says 8 by 14. Leave the length again, but come in side to side. I'm going to demonstrate the RPO because I think we'll have a better camera angle that way. With an RPO, I'm going to use a right marker. I'm going to move the marker in a ways because I have collimated in here. I'm going to let you take a look at that marker. The patient will be oblique to a 45-degree level. Okay? I'm going to have her reach this arm over her chest, bend this knee for support. Let's make this leg straight, more straight. This foot come back. There you go. And when you get your speed up there, you wouldn't have to use a sponge, but students tend to be a little slower than techs. I've pulled out a 14 by 17 positioning sponge to help that patient be more stable. And you just secure that sponge underneath them and then let them relax. Okay. Again, you want them straight on the table, so I'm going to adjust her just a little bit. There we go. Now you can extend that knee just a little bit. Is that more comfortable for you? Okay. I've kept the body at the entire same degree obliquity. Let's bring this arm up and over. You can just put it up above your head. That's good. So the shoulders and the hip are at the same degree of obliquity. Here we go. Okay? Again, the shoulders and the hips should be at the same degree of obliquity. My tube and my film are lined up. It's a floating tabletop. And now I'm going to find for a bony landmark. And I'm going to use the ASIS, that's the anterior superior iliac spine. You want to let the patient know that you're going to be palpating for bony landmarks on their pelvis. Give them some advance warning. I'm coming in with a flat hand and I'm feeling from the tummy side of the patient. I'm going to find that anterior spine. It's the most dominant, prominent point on the pelvis, on the anterior wall. And I want this crosshair, the one that goes head to foot, approximately 2 inches from that. It's the plane that's approximately 2 inches from that ASIS. I'm trying to put the patient's spine to the center of the film. I'm going to find the iliac crest. Again, I'm using my flat hands. You know, I can come from this relationship on both sides, find the iliac crest, and then the crosshair will be 2 inches above that. Okay. I'm using a right marker because this is demonstrating the right side. This will actually demonstrate the right zygapophyseal joint. I will use approximately 30% more mass than I did on my AP, and I would use the same breathing factors or breathing technique. Have your patient take in a breath, blow it out, don't breathe, don't move, and then you may make your exposure. Tell your patient to breathe and relax. Okay? You would do an LPO. Have your patient reach across her shoulders. That knee would come up. Notice how her hips and her shoulders aren't at the same plane and she's a little crooked. So we're going to adjust her, get her straight, use the sponge, and let her relax down. I'm going to change cassettes. And I'm going to use a left marker now, moving it in a ways. ID blocker to the bottom. I'm going to be demonstrating the left zygapophyseal joints now. Same collimated field, and I'm going to palpate for her ASIS, be approximately 2 inches medial to that. Find the iliac crest, flat hand, fairly firm, feeling posteriorly. And the center of the film is 2 inches above that point. Okay, make sure the elbow's not in the way. Hips and shoulders are at the same plane. Okay. I'm going to show you a trick that you can use here. I mentioned that you should be approximately 2 inches from the ASIS, the plane of the film, the central ray here. That distance should be 2 inches. I hope you can see that. There's another trick. I'm going to remove the sponge now just for teaching purposes. I'm going to palpate for her spinous process. Can you see my hands here? Okay. I'm going to feel for the spinous process. I'm going to take my upper hand and I'm going to match up my heel of my hands. I need to look right down them, and I'm trying to line up those 2 reference points. And this is feeling the spinous process, knowing that the body of the spine is a little bit more anterior. So when I line this up, these fingers will give me a reference with what I'm feeling here, and I will know that the spine is centered to the film. And when I look at the patient, the heels of my hands are lined up. And I don't know if you can see from this camera angle, but this crosshair here is just a little forward of my fingers. That has confirmed that I have the spine to the center of the film. So I'm very happy with how I've centered this side to side. Another trick with the patient size like Drea is, I can just look here from the head of the table, and the collimated box is basically centered right over that patient. Therefore, I definitely know that the spine is to the center of the film. So those are some tricks that might help you know how that you actually do have the spine centered to the film. Okay. So we've made our exposure, and now I'm going to have my patient turn way up onto her left side. Okay. I'm going to look at the pillow. I don't want her head dropping too much. You might want to double the pillow. Ask your patients how they're going to be more comfortable. Would you like the pillows a little tighter? You know, again, you might have to double the pillow. Okay. And I want the knees one on top of another. And for comfort, it's a very good idea to put a sponge between the knees. Okay? Knees one right on top of the other, the feet on top of one another, arms in the same position. And I want you to get the patient straight on the table, and I want them in the lateral position. So those are 2 things I'm going to work on right now. I'm going to go to the head of the table, and I can see that she's crooked. So I now have her straight, and I'm going to look at the shoulders to see if they're straight up and down, and I'm going to look at the small of the back to get her into a nice, true lateral position. Don't forget, I want you to look between the shoulder blades, and I want you to look between the small of the back. What I'm going to want you to do next is you need to analyze patients' shapes. Is the spine parallel to the table? Is the spine crooked? You don't know. Every body habitus is a little bit different. So when you're first starting out, I want you to actually physically lower your position with the patient, and I want you looking at the spine. And I'm going to feel her spinous process here. I think the camera can see. I'm actually palpating the spinous process, and I'm coming high on the lumbar region, and I'm going to palpate for the spinous process on a lower portion of the back. And what I'm seeing is we have the spine fairly parallel through this region, and then we slightly angle up. This is not at all uncommon. You might see a spine that angles up on a lot of women. Women tend to be broader in the pelvis, so the spine will actually kind of swing itself up. The reason I'm analyzing the spine here is you want to be perpendicular to the spine. So when I'm going to do my big film on Andrea, this patient, most of her lumbar region is parallel to the film. So I'm going to shoot perpendicular. I'm going to go back to a 14 by 17 cassette. And I'm going to use a left marker because she's on her left side. And I've put the left marker in a ways because I'm going to collimate. Tube and the film remain centered, so all I have to do is float my tabletop. And I do have 40 inches. I've had 40 inches throughout. I forgot to tell you that at the very beginning of the procedure. But we have 40 inches to the bucky. And the tube is transversely centered. Okay? Don't forget, tube should be transversely centered. Okay, I've got the patient straight. I've got her in a true lateral position. And your part film reference points are mid-coronal plane to the center of the film, and the center of the film is 2 inches above the iliac crest. Okay, so I'm going to find the iliac crest, feeling on the posterior wall. There's the iliac crest. I want to be 2 inches above the iliac crest with the mid-axillary line to the center of the film. Okay, what we do with that, because we're just starting you on spines, is with the arm down to their side, somewhat posterior. This crosshair comes right down the middle of the axilla. That's why they call it the mid-axillary line. This crosshair is coming right down the center of her arm. Once you've practiced this a few times, you won't have to put the patient's arm down to their side. You will just look and you can see where the spine is. Remember, there's not very much tissue on the back wall. You have spinous processes, and then right there is the lumbar vertebra itself. The lumbar vertebra is a very dense body part, and there's a lot of production of scatter. So I want the lead strip placed next to the body, not into the shadow of the body, but right up into the shadow, right next to it, real close. Okay? This will protect the film from unnecessary scatter radiation. We want you to use well, you'll be responsible to use a lead blocker behind the patient. Okay. So again, just to recap, patient is straight on the table in a true lateral position. The mid-axillary line is to the center of the film, and the center of the film is 2 inches above the iliac crest. My patient's spine was almost perfectly parallel to the film, so I left the tube in a perpendicular relationship. If the spine had angled, I would have put probably a 5 to 8 degree caudal tube angle on this particular patient. But since the spine was parallel, I did not. Again, you would measure the patient, have her take in a breath, blow it out. Then you would measure where the central ray goes, set your panel, make your exposure. We're going to do a little bit of demonstrating before I actually position for the next projection, which is your coned L5S1 lateral view. We're going to pretend that her spine was not parallel, that it was curved. You have a couple of options that you can use. I have another positioning sponge here, like a 15-degree sponge. To be more technically accurate, you should have the spine parallel. And what this does is you just have the patient lift up, and you would slide this sponge underneath their spine. Can I have you just lift up your shoulders up a little bit, Drea? Not quite. There we go. Thank you. That sponge would actually elevate the spine here, making it parallel. Okay? Use a sponge in the small of the back to make the spine parallel. Then you could keep your tube perpendicular. You could tell that it was not easy for me to slide this sponge underneath the patient. And believe me, a patient in pain, it would be even worse. Okay? So a lot of techs will not build the patient up on a sponge. More techs will choose to angle the tube caudal to maintain that relationship. And I mentioned if her curved spine, I would go 5 to 8 degrees caudal. Well, Drea, when I analyzed her spine earlier in the procedure, I did notice that in the L5-S1 region, we would need to have a slight caudal tube angle. So that's what I'm going to do now. We're going to angle the tube 5 degrees with Drea, not 8 because she did not curve very much. Somebody who has wide pelvis, we would have to angle the tube more like 8 degrees. Okay, so I have a caudal angle. I'm going to drop the tube down the 1 inch for that 5 degrees. I'm going to change cassettes to my 8 by 10. I'm going to collimate to within the film's edge. I'm going to show about 1 inch of collimation all the way around. And I'm going to leave the ID blocker to the bottom. Therefore, it's consistent with the procedure, all the other films that we took, adding to the aesthetic quality of the image. I moved my patient. When you're actually in the field, you would just, after you make your exposure on your lateral, just tell your patient they may breathe, but do not move. And then you don't have to straighten them back out. But when I was demonstrating the sponge, I actually changed her relationship a little bit. So I'm just double checking that her shoulder blades and the small of her back are nice and lateral and that she's straight. I have an 8 by 10 in the cassette holder, left marker. I need to collimate. There's 8 by 10, and then I'm going to come in a little ways. Okay. And we need to line our film up with our bucky tray again. If you look down at the film, I'm matching up the centering light with the center of the film. Can you see that? Shall I lower the light a little bit? We okay? Lower the light? Okay. Our centering light to the center of the film. Once I have my tube and my film lined up, I can push the bucky tray in and then ignore it from this point on. You are still going to have a lot of scatter production, so I use that lead blocker behind the patient again. The reference points now for the center of the film. You find the iliac crest, and you need to go 2 inches inferior to the crest. So here's the crest. I'm going to go 2 inches from that point. And then I feel for the anterior superior iliac spine, and I'm 2 inches back from that. And a lot of times patients, my 2 fingers will line up. They just match. They meet in the center, and that's where I'd put the central ray. In Drea's case, here's the crest, 2 inches down. There's the ASIS, and 2 inches back. I'm going to kind of compromise between those 2 points, and that's where I'm going to put the central ray. Again, 2 inches inferior to the iliac crest, 2 inches posterior to the ASIS. And then I compromise between those 2 marks on this particular patient. Many times adipose tissue will add to the, you won't get a true perception of adipose on top of the iliac crest or the ASIS. So we like to have a backup mechanism to help you out to localize L5-S1 joint space. So I'm going to give you those backup reference points. I think you can see me from this angle here. I'm going to actually go with my hand flat on my patient. I went with the flat hand, and I'm feeling for the trochanter. And I pivoted my hand up on the trochanter. And can you see this crosshair here? It's slightly behind my hand. I'm happy with that relationship. L5-S1 when we look at x-rays, you'll be able to see that the L5-S1 area is slightly behind the level of the trochanter. So if you feel the patient's trochanter, identify it, and you're slightly behind that, you've double-checked yourself and you should be okay. I might consider moving my patient just a fraction of an inch forward. And then I'll come in from this angle. And again, the patient won't be in pants, they'll be in a gown, and you can protect their modesty and just lift up the gown. I'm almost right there. Every one of us has the dimples. Remember the toilet paper commercial? And the little girl or the boy walking away from you? All of us have these two dimples right off the sacrum here. And Drea's are, all right, you know, I can feel them. You can actually, again, don't get too personal, but I'll come in from this angle like I would on a real patient. I'm feeling here, and I can work my way down, and the heel of my hand, I've learned to feel those dimples. If you can't see them, they're right here. And I'm going to reverse my position. Again, I wouldn't use my hand feeling this way. That could be too personal. Okay? Here I found the dimples, and if this crosshair, this one here, is coming right down through the dimples, I would be able to pretty much guarantee that you will have L5-S1 to the center of the film. Okay? Okay, let me review. Technically, to find the referencing, you use the iliac crest and you're 2 inches inferior to the iliac crest. ASIS, and you're 2 inches posterior. As a backup, in the field, you can find the patient's trochanter, flat hand, and this crosshair should be slightly behind the trochanter, and this crosshair would come down through the dimples. Collimated field, I'm showing about an inch of collimation all the way around. I move my L marker in. I have a caudal tube angle on, 5 degrees. On some patients you might need 8 degrees, or you'd have to build them up with a sponge to make the spine parallel in order to open up that joint space. And this would be the lumbar spine series. Drea, do you have anything to add or recommend?
No.
Okay. We'll let the patient sit up so she's more comfortable. We still want to talk for just a minute because I'm going to go over the positioning criteria information with you. The AP projection is on a 14 by 17. Mid-sagittal plane is to the center of the film. Iliac crest is 2 inches below the center of the film. To look at that radiograph to determine if you did truly do a good AP, you would look at the wings of the ilium. The wings of the ilium will be symmetrical, the same size on both sides. As a backup reference, you can look at the spinous process. They should be to the center of the vertebral bodies. That would be your AP. Your obliques, we're after L1 through L5 in most cases. With an L1 through L5, you want a 45-degree patient obliquity. An RPO would demonstrate the right zygapophyseal joints, and your evidence, well, you will see the Scotty dogs. And we'll be talking about the Scotty dogs in another lesson. You'll be labeling them on a radiograph diagram in your workbooks as well. An LPO would demonstrate the left zygapophyseal joints. And again, you'll see the Scotty dog. The pedicle of the Scotty dog, the eye of the Scotty dog should be right in the center of the vertebral body. If spina bifida is of concern, many times in the Seattle area you will see follow-up studies for spina bifida. That's usually in the L5-S1 area, lower in the lumbar vertebra, and you would only have a 30-degree obliquity. And you could use an 8 by 10 and focus right down on the L5-S1 junction. The lateral, the 14 by 17, you want the mid-axillary line to the center of the film, and the center of film 2 inches above the iliac crest. To determine if you did a good job positioning, you're going to look at the posterior walls of the vertebra, Both sides should be superimposed on one another. You shouldn't see a double wall. And the intervertebral disc spaces should be open. You should not see the drum effect. If you see the drum effect, that means the intervertebral disc spaces were not open. That means the spine was not parallel to the film, or you failed to angle the tube to compensate. If you see posterior walls not superimposed, that means the patient wasn't in a true lateral position. Make sure you separate out those two concepts. Spine is parallel, you will not see the drum effect. If the patient is not lateral, you will see double posterior walls. On the L5, S1, the same criteria. If the patient is in a true lateral position, the posterior walls of the vertebra will be superimposed. If the disc space is not open, your spine was not parallel or you failed to angle the tube appropriately. Okay. That was a good review of PFRs, PCs. I failed to tell you PFRs on the L5, on the obliques. And so you want to be 2 inches medial to the ASIS, and you want to be 2 inches above the iliac crest for the 45-degree obliques. And that concludes our lesson on lumbar spine.